Welcome to the Tobacco Online Policy Seminar. Thank you for joining us today. I am Sang-Yun Lee, a PhD candidate in economics at University of North Carolina, Chapel Hill. So TOPS is organized by Mike Pascoe at the University of Missouri, Tu Xiang at the Ohio State University, Michael Darden at Johns Hopkins University, Jamie Hartman Boyce at University of Massachusetts Amherst, and Justin White at Boston University. The seminar will be 1 hour with questions from the moderator and discussant. The audience may pose questions and comments in the Q&A panel, and the moderator will draw from these questions and comments in conversation with the presenter. Please review the guidelines on tobaccopolicy.org for acceptable questions. Please keep the questions professional and related to the research being discussed. Questions that meet the seminar series guidelines will be shared with the presenter afterwards, even if they are not read aloud. Your questions are very much appreciated. This presentation is being video recorded and will be made available, along with presentation slides, on the TOPS website, tobaccopolicy.org. I will turn the presentation over to today's moderator, Justin White from Boston University, to introduce our speaker.
Today, we continue our summer 2025 season with a single paper presentation by Orestis Efthimiou entitled Personalized Counseling on the Use of E-Cigarettes to Achieve Tobacco Abstinence, Secondary Analysis of Data from an RCT. We are also commemorating TOPS' 5-year anniversary and 112th seminar, so thank you to all who have contributed to making this seminar series a success over the past 5 years. Dr. Orestis Efthimiou is a biostatistician working at the University of Bern, Switzerland. His work is focused on the development of new statistical methodologies, covering a wide range of areas, including evidence synthesis, prognostic modeling, and personalized medicine. Apart from methodological developments, he has also led or collaborated in several practical applications in a wide range of fields, including mental health, oncology, cardiology, surgery, and others. Dr. Reto Auer, an associate professor at the University of Bern, is a co-author of the study and will answer select questions in the Q&A. Dr. Efthimiou, thank you for presenting for us today.
Thank you for introducing me, and good evening from Bern, Switzerland. So let me start by sharing my screen. Okay. Yeah. Okay. The title of this talk is Personalized Counseling on the Use of E-Cigarettes to Achieve Tobacco Abstinence, Secondary Analysis of Data from an RCT. And this has been done in collaboration with colleagues from the University of Bern in Switzerland. I will not go through all the names. I just want to mention again Reto Auer, who is on the call, and he is the principal investigator of the EST-EXTENS randomized trial, whose 6-month follow-up data was presented by him last year in the TOPS seminar. This presentation by me today is using again the 6-month follow-up data. The study is ongoing and data at later follow-ups are still being collected. So I'll start by saying that we have no conflicts of interest to disclose. Now, the background, e-cigarettes, also called electronic nicotine delivery systems, ENDS, are used by some people that smoke tobacco to help them quit smoking. And it has been shown that these cigarettes generally tend to increase tobacco abstinence, but do not necessarily increase nicotine abstinence. So presenting therapy options for helping people stop smoking should incorporate patients' preferences and values regarding both tobacco abstinence and nicotine abstinence to enable a shared decision making. And I will be using these abbreviations TA and NIA throughout this presentation to denote tobacco abstinence and nicotine abstinence. So you may have individuals who are motivated for tobacco abstinence, but not necessarily about nicotine abstinence, in which case e-cigarettes might be a viable option. Or you might have people who are motivated for both tobacco and nicotine abstinence. In this case, we might say that the cigarettes should not be, is not the best option. Maybe cetirizine or varenicline might be better suited. So when counseling patients, we could inform them about characteristics in our trials for whom the intervention, so giving them e-vapes, had a high or a low effect on tobacco abstinence, while also considering the effects of the intervention on nicotine abstinence. To make it more explicit, the aims of this project was first one to predict the effects of e-cigarettes for both tobacco abstinence and nicotine abstinence at the individual level. Then to validate the predictions, and third, if these predictions are validated, then develop an online tool that can be used to implement these models in everyday practice. So to what we actually wanted to know is, for a new individual with X characteristics, what outcomes on tobacco abstinence and nicotine abstinence do we expect based on our trial data? Or how to identify people who will have higher treatment effects, so high benefit from vaping devices, meaning an increase in the probability of tobacco abstinence without a great decrease in the probability of nicotine abstinence, and also people for whom we expect lower treatment effects, so low benefit. People for those that the vaping devices might decrease both the chances of tobacco and nicotine abstinence. So to answer these questions, we used data from the EST-Extends trials, stands for efficacy, safety, and toxicology events. This was a randomized trial on adults, so age above 18 years old, people smoking at least 5 cigarettes a day and willing to set a quit date. The control group was standard of care smoking cessation, smoking counseling. I will denote that as SOC, standard of care. There were 30 minutes of counseling at the baseline visit and then 2 months of phone counseling. The intervention group was standard of care plus free e-cigarettes and choice of e-liquids for 6 months with no specific advice on e-liquid use or duration. The study included 1,246 participants randomized at a 1-to-1 ratio between 2018 and 2021. In 5 sites in Switzerland, people were initially followed up at 6 months, but now the study continues. So this study was published in the New England Journal of Medicine. I have the link here and also the reference. So for this project, the outcomes that we focused on was continuous tobacco abstinence, defined as self-reported tobacco abstinence for 6 months. This was the first outcome. The second outcome was 7 days tobacco abstinence. This was biochemically validated abstinence for the last 7 days before the 6-month visit. And the third outcome was 7 days nicotine abstinence, again, biochemically validated for the last 7 days before the 6-month visit. So these were the outcomes. The predictors that we used in order to make predictions about the effects of the intervention was sex, age, PHQ-9 score, which measures depression, depression symptoms, time to first cigarette of the day, a categorical variable which was defined, which had 4 categories: above 60 minutes, 31 to 60 minutes, 6 to 30, and less than 5 minutes until the first cigarette of the day. Then we had number of previous smoking cessation attempts, cigarettes per day, years of smoking, whether someone had tried to quit via e-cigarettes before, so yes or no, and also use of psychiatric medication, yes or no. Now, this list was predefined, so it was based on clinical experience, but without checking whether these variables were actually predictive of the outcome. And this is something which is related to overfitting, which is something I will be discussing again later in this presentation. So here is an overview of the baseline data. Around 52 to 53% were males. The mean age was around 41 years old. People smoked for a mean duration of 22 years. So here I have the data in terms of the time to first cigarette of the day. So most people did their first cigarette within the first 30 minutes. People they had already tried to quit smoking with a median of 2 times. The median cigarettes per day was 15. 17% of the individuals participating in this trial had tried e-cigarettes before. Around 16 to 17% had tried e-cigarettes before while trying to quit. The mean PHQ-9 score was around 4.4 to 4.5, and around 18 to 20% of the participants reported the use of psychiatric medication. Okay, and before I go into the next part of the presentation, which is about the methods we used, I will stop here and see if there are questions regarding the data.
Perfect.
And again, just to know that I'm a biostatistician, and I will have Reto here helping me out with questions related to the data or to the study itself.
Great, thanks so much. So unfortunately, we had a last-minute issue with our discussant today, so I will be filling in that role. I would encourage our audience to submit any of their questions in the Q&A, and we will direct those to the presenter. Maybe Orestis has a little bit of background. I think it's safe to say that most people in our audience are not in Switzerland. And so I'm wondering if you could say anything about sort of, smoking and vaping prevalence in Switzerland, or anything sort of about maybe about the e-cigarette regulatory environment there, sort of relevant background about for sort of interpreting, especially how your study context might differ from other settings.
Yeah, for that I will need Reto's help. So.
Yeah, hello. Thank you so much for these excellent questions. Do you hear me well?
Yes.
Good. So this trial started in 2018. In Switzerland, e-cigarettes were allowed, but without nicotine, and nicotine was allowed only in 2017. So, and recruitment went from 2017 to 2021. So there is a gap, 2018 to 2021. And so there's a gap in maybe the experience of participants, how much they have been exposed to e-cigarette. Switzerland, when they allowed nicotine, aligned with the TPD in Europe. So nicotine is typically a maximal of 20 milligrams per milliliters. You don't have these limits in the US. The smoking prevalence is high. About 25% of the population report smoking in the last month, and that hasn't budged so much in the last years. And currently there is a wide range of availability of nicotine products, ranging from tobacco heating system, or one of the testing field for the industry for these products. And since 2021, the nicotine pouches and snus is also becoming prevalent. On the exact proportion of the population using e-cigarettes regularly, there's not that much good estimates about this. It might be about daily users, about in the 2 to 3%, or maybe 10 to 20%, and that's really different between young and adults. I hope that answers a little bit.
Yeah, that's very helpful. I think also maybe while you're here, or maybe Orestis wants to say this, I didn't see anything in the rest of the slide deck about sort of the main findings from the RCT. For those people who were not able to attend your talk, I think it might be helpful context for interpreting the secondary analyses. I wonder if you could just say a little bit, sort of a quick summary of sort of like what the main findings were from the RCT.
Sure. So there's on the exposure. I mean, it's in the appendix of the adherence to the intervention, in the appendix of the publication, one can find this. So the standard of care, about 80% had in the control group, the intention to use nicotine replacement therapy, about 60% reported using them at 1 week, and also 5% e-cigarettes that they used on their own, and about 5 to 7% using also further smoke cessation drugs. And that then got down over time. The adherence to the intervention at the beginning was about 89% reporting using e-cigarettes at the first week, and then going down to about 40% at 6-month follow-up. So the control group did get an intervention, right? So it was standard of care. There was smoke cessation counseling, and people could use nicotine replacement therapy who were not provided for free, but were given a voucher kind of to make to equilibrate a little bit the groups about the monetary amount of the e-cigarette the others received. And so the main results were a significant difference, and main continuous smoking abstinence outcome, and also 7-day point prevalence. I need to pull out the numbers now to not say anything wrong, but it was a relative risk of 1.77, and the continuous abstinence went from 16% in the control group to 29% intervention group. But we also looked into, well, who was continuing to use the nicotine. And as you know, people continue using e-cigarettes. And so you had more people continue using nicotine you had more people who were abstinent. I'm sorry. So those who so then when you look at the last 7 days, you had 60% were abstinent from smoking in the last 7 intervention group, and 38% control group. And those who abstained for any nicotine was 20% intervention group and 33% control group, suggesting that while you had more people who abstained from tobacco, you had less people who abstained from nicotine. And that's the question now Orestis tries to answer, is who is who? And can we identify those who stop smoking, don't continue using nicotine, or those who can stop smoking and continue using nicotine, and these different groups?
Great. Thank you so much. Okay, so I think in the interest of time, I'll pass it back to Orestis. And there's one question in the chat, but if that doesn't get answered by Reto before the next pause, we'll ask that later. So go for it, Orestis.
Okay, so on the methods, so the first thing we did is, again, try to estimate the average treatment effect of each outcome. So we estimated the risk difference, meaning the probability of an event in e-cigarettes minus the probability of an event in the standard of care group. So here, because the outcome is defined as abstinence, and risk difference above 0 means that e-cigarettes are better, so they increase abstinence. So in all results that I will show, whenever I show a risk difference above 0 means e-cigarettes are better. Whenever I show a risk difference below 0 means standard of care is better. So this was the first thing was the effects on average, and the second was try to actually go into the participant level. And for that, we fit a series of statistical and machine learning model for each outcome separately. So we used a series of models, including logistic regression, also logistic regression with all treatment covariate interactions, penalized regression models, that is lasso and ridge, and some machine learning models, including gradient boosting machines and causal forests. So I will not go into the detail of what exactly all these models are doing, but the main idea is that the input of these models are the baseline, the patient predictors that we discussed, so age, sex, and so on and so forth. And the output of these models is a probability of an event for all 3 outcomes and for both interventions. So we have three outcomes: continuous tobacco abstinence, 7-day tobacco abstinence, and 7-day nicotine abstinence. And we have two interventions: e-cigarettes and standard of care. And from these probabilities for each outcome, we can estimate the effect of the intervention as a risk difference. So for each patient and for each outcome, we get a probability, a predicted probability of abstinence, let's say, under e-cigarettes, and the predicted probability of abstinence under standard of care. The difference between the two is the risk difference, which encapsulates the treatment effect, the effect of e-vapes for this particular individual. So after fitting the models, we needed to assess which model was best and whether the models could actually do anything, could actually predict. So for that, to assess the model performance, we followed an internal and an internal-external cross-validation approach. So maybe for some of you in the audience that know about prediction models, this is a standard procedure when assessing model performance. So I will very, very quickly outline what this is. So for internal validation, we use the 10-fold cross-validation, repeated 20 times. So here is a simple graph of how this works. So the idea is that we do not want to test the model in the same data that it was used to develop it. And the reason behind that is that we can easily create a very complicated model that performs perfectly in the data that it was developed, but still this model may be worthless when we apply it to new individuals. So this is something called overfitting. So in order to assess a model performance while avoiding this situation where the model performs seemingly perfectly but actually is worthless, we follow this 10-fold cross-validation approach, where the idea is that we split the data in 10 random folds. Then we take one fold out and retrain the model again at the remaining 9 folds, and then test the model performance in the left out fold. And then we cycle through all folds. So then at the end, we have 10 measures of performance. And then we summarize these 10 measures of performance. And this is an assessment. This gives us an assessment of the overall model performance. And crucially, this allows us to get this assessment without using the same data that was used to develop the model. So this is an internal cross-validation using a 10-fold cross-validation approach. Then we did something called internal-external validation, which is the idea is similar to the internal validation, but now the folds are not random. In this case, we used the 5 sites where the trial was conducted. So again, we took one site out, used the remaining 4 sites to train the model, test the model in the left out site, and then cycle through all sites. We did not do an external validation approach following recent guidelines, and I realized that the citation I am giving has my name, so it seems a bit secular, but it's not only me that's recommending against external validation. I just give here the paper where we have this discussion. Okay, so how to assess model performance? When we have models predicting a risk of an event, the usual approach is to measure something called calibration and discrimination. And this tells us how good the model is in identifying people who will have the event rather than those who won't have the event, and also tells us whether the model is well calibrated. So when a model gives 30% probability of an event, it is indeed 30 and it is not 10. And the usual way to do that is via something called area under the curve, so AUC, and the calibration slope. However, and this is not something that is not something that people have been doing so much in the literature, but it's quite crucial. It is that when we are interested in treatment effects rather than predictions, we need to assess the performance of the model for predicting the effects and not absolute risks. And this is because you can have a model that minimizes the error of outcome predictions, so absolute risks, but at the same time, it not minimize the error of treatment effect predictions. So you may have a model that predicts absolute risks very well, but at the same time does not predict risk differences. So in our case, the target is risk differences because we want to know the effect of the intervention. So in order to do that, to assess performance on that, we used some recently developed methods that allow the assessment of performance in terms of discrimination for benefit and calibration for benefit. So these are measures that directly target effects, treatment effects, predicted treatment effects. And after doing that, so after doing an internal cross-validation and measuring these performance measures that I discussed, we selected the model. So we selected the best model. And then we used this model to predict the treatment effect for each participant. And then we used these predictions to define two groups. And for that, we used the percentiles of predicted effects. So we call these two groups the high benefit group and the low benefit group. So in the high benefit group, we had the participants in this group were predicted to have a high benefit from e-cigarettes with respect to tobacco abstinence without a substantial deterioration in the probability of nicotine abstinence. So in this group, people were predicted to, via e-cigarettes, to increase the chances of tobacco abstinence without decreasing too much the probability of nicotine abstinence. On the other side, we had the low benefit group. So people in this group were predicted to benefit less from e-cigarettes with respect to tobacco abstinence, while at the same time they might increase their probability of nicotine abstinence, even if they achieve tobacco abstinence. So in this case, in this group, there were people for whom the model said that e-cigarettes will not help them so much in quitting tobacco. And even if they do manage to quit tobacco, then they decrease the probability of also quitting nicotine. So they decrease the probability in both tobacco abstinence and nicotine abstinence. And after identifying these two groups, we summarized their characteristics and compared these characteristics to see how they compare and whether we can take something out of this information. One thing that always complicates things when it comes to analysis, of course, missing data. Luckily, we had very, very few missing data on covariates. However, we did have missing data on outcomes. This was more frequent. Around 10% of the people we did not have information on the outcomes. The usual way that people address the missing data is via imputations. So usually multiple imputations, but in this case, we could not really do imputation because we did not have additional information that could be used to reliably impute the missing outcomes. So in this case, we performed a complete case analysis. So we removed participants with missing outcomes or covariates from the data. And in sensitivity analysis, we repeated the analysis after assuming that all missing outcomes were negative. So no tobacco or nicotine abstinence. And then we compared results with the primary analysis. So before showing results, I will make another stop to see whether there are any questions on what I presented on the methods.
Yeah, great. I think you did a nice job of describing them. Maybe just one or two questions. One is when you were defining the high benefit group and the low benefit group, you mentioned you used the 33rd percentile and 66th percentile. And I'm curious about sort of maybe why you chose those, or if you tested sensitivity to other cutoff choices, and if, or even maybe using something like quartiles or something less coarse.
Yep. So this part of the analysis was more exploratory. So the models did not change. The predictions, the patient level predictions were fixed. So the model was fixed. So we wanted to somehow get an idea of what is important for the models. And yes, indeed, we tried also other quartiles. I think in the manuscript, we will have also presenting splits according to medians or quartiles. Of course, the more you split, the less people you will have in each group. So if, as I will show later on the results, These two groups that were created in this way had around 150 people in each group. If we kept higher and lower percentiles, so people that really had very high predicted benefit or very low predicted benefit, then there would be too few of them. So yes, we also checked this in sensitivity analysis. That's the short question. This is an arbitrary choice. We did other analysis by using other percentiles as well, and it doesn't really affect the results that you will see.
Okay, great.
That's a very good question. Thank you.
So you mentioned that you tried multiple different machine learning models and statistical models, and then you chose picked one based the best performing one. If I understood correctly, it was based on discrimination and calibration, those sort of two metrics. Is there like a way that you combine those two, or how did you sort of decide globally what was the best performing when you have those multiple criteria?
That's also a good question. So the idea is that there are measures that can combine discrimination calibration, like R-squared, for example. This is a combination of the two. But in this case, for some models, it was very clear that they did not work. So I will show calibration plots later in this talk in the results section. For some models, it was completely obvious it did not work. So the discrimination, I think that for the models that had good calibration, the discrimination was more or less the same. So there weren't many big differences in the discrimination. So we based our choice only on calibration at the end, because there was no real difference in the discrimination for those models that actually seem to work.
Great. Okay. I'm not seeing any other questions from the audience. I'd like to encourage everybody to, if you have questions, please put them in the Q&A. And otherwise, why don't we jump to the results?
Okay. Okay, so I will present results first by outcome, starting from the continuous tobacco abstinence. So the average treatment effect in the data set we had was around 13%, so plus 13%. And again, I remind you that a positive risk difference means increased abstinence in e-cigarettes. So here we have plus 13%, meaning that e-cigarettes increased the chances of tobacco abstinence by around 13%. So this is the results on average. When we went to the patient level or participant level prediction, we found that the best model was READS. In terms of performance, it had modest discrimination, an AUC around 0.61, and modest calibration with a calibration slope of around 0.85. The predicted treatment effects range from a risk difference of -4% to plus 26%. So the model predicted that there were, for some patients, predicted a benefit of plus 26%, meaning that there were participants in the data for whom the model predicted an increase of 26% in the probability of tobacco abstinence if they go for e-cigarettes rather than standard of care. And the minimum was -4%, meaning that there were some participants for whom the model thought that the standard of care is better. The discrimination for benefit, which is measured by something called C for benefit, was rather low, 0.56. But this is something that for those of us who have been doing work on personalized medicine, this is not a surprise. This is the usual case. So this is something which seems low, but in practical applications, we haven't seen anything more than that, maybe up to 0.60. So it seems low, but it's actually rather moderate, I would say. However, we found good calibration for benefit with a slope of 0.99. So again, these numbers now seem a bit, might seem a bit arbitrary, or it's hard to understand, but I will show later a couple of slides. I will show in a graph what this means exactly. Then we went to the second outcome, 7 days tobacco abstinence. And again, this is 7 days before the 6-month follow-up, and this is biochemically validated tobacco abstinence. The average treatment effect was a risk difference of around 21% favoring e-cigarettes. So this is on average. So again, the use of e-cigarettes increases the chances of tobacco abstinence. They have a beneficial effect for that outcome. When we went to try to predict the effects at the patient, at the participant level, we could not, unfortunately, develop a good model. So all models showed very bad performance when we did the cross-validation. So we concluded that we are unable to develop a model to reliably predict effects at the individual level for this particular outcome. And finally, we went to the third outcome, the 7 days nicotine abstinence. The average treatment effect for this outcome was negative, a negative risk difference, so minus 14%, which means that standard of care was favored. So in other words, people that got e-cigarettes had on average 14% smaller chances of nicotine abstinence at 6 months as compared to standard of care. When we went to predict the effects at the individual level, we found that again, ridge regression performed best. Again, modest discrimination, AUC around 0.64, but good calibration. The predicted treatment effects range from minus 28 to minus 2%. So the model thought that everyone in the data set would benefit from standard of care rather than e-cigarettes. So there were no participants for whom the model predicted a positive effect if they switched to e-cigarettes. The discrimination for benefit was again around 0.55, but the calibration for benefit was quite good. So in this graph, I try to show what a good calibration for benefit means. So these are the two outcomes for which we were actually able to develop a prediction model for the for the participant level treatment effects. So on the x-axis here, on the left, I have continuous tobacco abstinence. On the right, nicotine use abstinence. On the x-axis, we have the predicted treatment effect, meaning risk difference, e-cigarettes versus standard of care. And on the y-axis, we have the observed risk difference. So if you look at the left plot, on the right, I'm not sure if you can see my pointer, but anyway, so here we have four points in the graph. Each of these points corresponds to a group of people. So the groups here were created according to their predicted treatment effect. So the bullet on the top right were people for whom the model predicted a high benefit. So the benefit here was around 17%. And indeed, this group of people, when we actually went and looked at what is the observed treatment effect, because in this group of people, half of them were randomized with cigarettes and half of them were randomized to standard of care, the observed treatment effect was around 19%. On the other hand, we had the model identified a group with low predicted effect, so that the treatment effect that the model predicted was around 6 to 7%, and the observed treatment effect was around 10 to 11. So it was a bit miscalibrated, but again, the model was able to identify people with lower benefit in terms of tobacco abstinence. If you look at the right graph for nicotine use abstinence, here the calibration is almost perfect. So you see here on the right top, there is a group of people for whom the model predicted a low benefit, in this case it's harm, so it's the risk difference is negative, meaning that e-cigarettes reduced the chances of nicotine abstinence. But this group here, the predicted and also the observed effects, so the observed risk differences were relatively small, around 5%. While at the other side, there was this group here on the bottom left of the graph, for whom the model predicted a reduction in the probability of nicotine abstinence by around 20%, and indeed the observed treatment effects were around minus 20%. So in this case, you can see that the model was quite well calibrated, so it was able to identify groups of people for whom the use of e-cigarettes might lead to a great reduction in the probability of nicotine use abstinence, or groups of people for whom the e-cigarettes would lead to a less reduction of this probability. So now, after having our two models, so we create again two models, one for continuous smoking abstinence and one for nicotine use abstinence. And as I said, we could not create a model for the 7-day smoking abstinence. So after having our two models and predicting the treatment effects at the patient and the participant level, we created these two groups, the high benefit and the low benefit group. Again, here, what I will show is out of sample results. All the results I'm showing in this exhibition is out of sample, so it's not affected by overfitting. So here we have the high benefit group. There were 117 people in this group. And now I show the observed treatment effects for this group. So you see here that in the high benefit group, the average treatment effect for continuous smoking abstinence was plus 13%, while in the low benefit group, it was only 2%, and with loads of uncertainty, which means that the low benefit group, people that the model identified as people that could not, sorry, the people for whom the model predicted no benefit from e-cigarettes, indeed there was no benefit for the continuous abstinence outcome. For the 7-day smoking abstinence, although we could not create a model for that, we could still look at what was the outcomes for these individuals here. So these are the observed outcomes. So for the high benefit group, we saw a positive effect, plus 30% in the risk of in the probability of tobacco abstinence for the high benefit group, while only 22% for the low benefit group. And for the nicotine use abstinence, you see that the high benefit group, the effect of the smoking was again negative, but only 9% as compared to minus 23% for the low benefit group. So overall, the people in the high benefit group had a higher probability in continuous smoking abstinence, 7-day smoking abstinence, and relatively smaller negative effects in terms of nicotine use abstinence. While people in the low benefit group did not get any benefit at all from e-cigarettes with respect to continuous smoking abstinence, had a lower benefit in terms of 7-day smoking abstinence and a higher negative effect with respect to nicotine use abstinence. And let's see now the characteristics of these two groups. So the high benefit group tended to be women, so 88% of them were women, while in the low benefit group it was only 20%. The high benefit group tended to have older people, 51 years old, smoking for a mean duration of 33 years, while in the low benefit group it was much younger people, 32 to 32.6 years old on average, with a smoking duration of 14 years. It's also interesting that in the high benefit group, none of the people had tried e-cigarettes to quit before, 0%, while in the low benefit group, 65% had tried it before. And also there was a big difference in terms of the psychiatric medication, 36% in the high benefit group versus only 6% in the low benefit group. And just to make these results, to show these results a bit outside the models that we created. So all these models are quite complicated, but this is a much simpler picture here, although it's quite busy, it's quite simple. So what it shows is the people grouped by their baseline variables. So here we have males versus females, smoking duration above or below 20 years, and so on. And here we have the average treatment effect for the three outcomes for the two groups. So you can see here, if you look at the first row, you see here that for the continuous tobacco abstinence, the effect was better in females rather than males, also for the 7-day abstinence and for this nicotine use abstinence. And again, a risk difference, a positive risk difference, so a risk difference that goes to on the right on this graph means e-cigarettes are better. The same picture was for smoking duration. Again, also, if you look at in the subgroup of people that had tried e-cigarettes to quit before, you see that if they hadn't tried, the effect was around 15%, but if they had tried, it was only 0.7% for continuous tobacco abstinence, and likewise for 7 days tobacco abstinence and nicotine use abstinence, the results were quite different. So this is just to show that the groups, that the models, the personalized models identified, were actually supported by this simple analysis. So now that we had developed two models for predicting individual effects for the two outcomes, so continuous smoking abstinence and 7-day nicotine abstinence, we created an online tool. You can access it in this link here. There's also the QR code. So in this tool, you can input participant level characteristics on the left, and then you get real-time predictions of the effect of the intervention. So in this example I have, there's a male of 36 years old that smoked for 16 years, for PHQ-9 score of 5. This person is smoking 12 cigarettes per day. He has tried 10 times already to quit smoking. The time of until the first cigarette of the day is half hour to 1 hour. He's not taking any psychiatric medication, and he has tried e-cigarettes before to help him quit smoking. So for this person, our model suggests that the effect of the intervention, the effect of giving e-cigarettes, it's only 5%. So the predicted probability of tobacco abstinence with interventions is 37%, and the probability of continuous abstinence, tobacco abstinence from standard of care is 32%. So there is an added 5%, so a small effect of cigarettes. While if you look at 7-day nicotine abstinence, there is a huge effect in favor of standard of care. So there is a 30% reduction on the probability of 7-day nicotine abstinence if this person is cigarettes. So that's just an example of how this model can be used. So sensitivity analysis on missing data, when we assumed all missing outcomes to be failures, we got similar results. So I don't have much to say about this. So to summarize, first, some limitations. We only used the 6-month follow-up, and maybe the effects we see are attenuated at later follow-up periods. This is something that hopefully we'll be doing in the future at some point when we have new data from the trial. An important limitation is that this is just one RCT conducted only in Switzerland, and results might not apply to other populations. The sample size was limited, and that's because this RCT was not powered for this exercise. This RCT was powered to detect average effects, and this limited sample size probably was the biggest reason why we saw low predictive performance for 7 days tobacco abstinence, modest performance for continuous tobacco abstinence, and 7 days nicotine abstinence. Also, we did not examine any side effects here. So I used the term high benefit, low benefit, but this only applies to tobacco and nicotine abstinence. It doesn't apply to any other sort of outcomes. On the strengths, this is, at least to my knowledge, the largest RCT in the field. I may be wrong here. Apologies if that's the case. We used cutting-edge statistical methodologies for model development to avoid overfitting and also for assessing model performance. And strength was the very few missing data on the predictors. We did have some missing data on the outcomes, around 10%, but sensitivity analysis suggested it might not be a big issue. And one strength was the good calibration we got for benefit. So the curves I showed you. So in the future, we would like to externally validate the model before implementing the models in clinical practice. Perhaps it will need to be recalibrated or updated if it's going to be used in other populations. So again, this is something that is quite often done in the world of prediction modeling. So you have a model that is able to discriminate among people that will have the event or not, or won't have the event, but it's not well calibrated when you take it to different settings or different populations. So maybe this is also the case here. Maybe we need to recalibrate it to use it in other populations or settings. Or even better, redevelop the model using more data in individual patient data meta-analysis. So this might increase the predictive performance of the models because, as I said, we only use data from one trial, and the trials are just not powered for this type of analysis. So to conclude, we identified high and low benefit groups, and particularly older women, and especially those who had already tried cigarettes before in order to quit, and those who are on psychiatric medications. These people might increase their chances of tobacco abstinence from adding e-cigarettes to standard of care compared to standard of care alone. And there was only weak evidence of a possible small negative effect of nicotine abstinence. So maybe these are the people for whom we should focus, we should target with this intervention. On the other hand, younger men who had already tried cigarettes before in order to quit, we saw that for these people, giving them e-cigarettes, we might not increase the chances of tobacco abstinence. And even if they do at the end manage to quit smoking, by giving them e-cigarettes, we might decrease their chances of nicotine abstinence. So maybe this is not the target, should not be a target for this type of intervention. So future research is required to validate our tool and corroborate its usefulness, hopefully in different settings for different countries, different populations, and so on. And if this model is validated with further data, then the online tool could be used to make personalized recommendations and empower and facilitate said decision making. So thank you for your attention, and I will close with showing these two pictures. On the right is Ioanna from Greece, so this is my hometown where I grew up, and on the left is my the city I'm living now, in Drenthe also. This is the capital of Switzerland, Bern. So thank you.
Thanks so much. Those are some beautiful cities. So maybe if I could start with questions around, I thought some of the findings around who is in the high benefit group and the low benefit group was really fascinating. And it makes sense to me that, you know, people who have tried using e-cigarettes in the past and failed are less likely to be in the high benefit group. There are really startling differences by sex, as well as the use of psychiatric medication. Do you have thoughts about why those factors are so have such sort of predictive value to them?
Well, this has there are two sides to your question. One is the statistical one, which I might try to answer, and the other one is the clinical one, which I might ask Reto to answer. So yeah, we can also show this picture where it also breaks it down by sex. So what I can say is that there were differences according to sex, and there were differences according to whether you had tried via cigarette to quit via cigarettes before. But I cannot say whether this is one of the two is like a causal factor or not, because there might be also correlations between them. So it might be the case, I don't know by heart, but it might be the case that males had tried to quit at higher percentages as compared to females. So this might be the driver rather than sex alone, or it might be some other correlation. So It might be that the females in the data set also had more psychiatric medications rather than males, because at least that's something I know, that the depression is not evenly distributed across the sexes. So it's not easy for me from a statistical point of view to give you what you're actually asking is for causal factors. What is the thing that is driving the results? But I cannot answer this because we did not do this kind of analysis. What I am showing here are correlations actually rather than causal factors. So that's from a statistical point of view, the answer is I don't know, in short. I don't know in terms of the medical or the clinical background, whether Reto has some insight, some better insight.
I'm glad to answer the question. The time is running, so I'll be quick. Well, I was really surprised by the results, I guess the audience too. And I think given the discussions around e-cigarette, that's my clinical daily, I'm a primary care doc, and that's my lived reality. I thought these are also person we want to help with quitting. And I think if this is true, might also change the perception, at least it changed mine to say, well, maybe we should try these out with these women. And at the same time, I don't know who participated in the trial in the low benefit. Maybe there were young people who said, hey, I can get free e-cigarettes. I don't know. And that's the reason why they didn't really quit, because they already tried before. I think we need to go back to the data, publish the results, see the peer review process and all this to see if it's true before we do causal. And I really want to point out this is in Switzerland extent and might be really different in other settings.
Great. I know we have just 1 or 2 more minutes. I just want to remind people that there will be top of the tops after this, and the link is in the chat for anybody who wants to continue the conversation. Maybe one other question would be this online tool that you created is really great. If this ends up being externally validated, it seems like this could help with personalized smoking cessation support. And I'm curious about how you would envision this sort of being integrated into clinical practice or workflows, or do you have sort of a plan for how this could be used in clinical care?
So there's a new, I think in the era of e-cigarettes, we have to ask 2 questions. One is, do you want to quit smoking? The second is, do you want to continue nicotine? And we don't include that in guidelines. And I do that in clinics and say, well, how do you feel? Do you have a problem with with nicotine? Nicotine, yes, it's not ideal, but it's addiction. But if you don't have a problem with it, so that's something we discuss. And so that might be helpful in this kind of discussion, saying, look, based on these different trials have been conducted in different settings, this is what you could expect. And at the end of the day, people then can decide. I think we also embrace schedule making and many tools to quit smoking. They're in the path in clinics, a couple of minutes with us, and then continue when they're out. And so there are many options available to them to quit, and informing them about this could be integrated in this kind of setting.
Great. Well, I think we are out of time, so I'm going to turn it over to our MC. Thanks so much for your presentation.
Thanks, Orestis. Including.
Thank you for having me.
We're out of time. However, if you still have burning questions or thoughts for Orestis Efthimiou, you can join us for tops of the tops on interactive group discussion. To join, please copy the Zoom meeting room URL posted in the chat and switch rooms with us once this event concludes. We will leave this webinar room open for an extra minute after the end to give everyone a chance to copy the URL, which is bit.ly/topsmeeting, all lowercase. Thank you to our presenter, moderator, and discussant. Finally, thank you to the audience of 117 people for your participation. Have a top-notch weekend.